Hello everyone. Today I would like to discuss a problem that is quite prevalent but just does not get discussed a lot, and that is the problem of the distalization of the maxillary second molar. Now generally when a maxillary second molar has the third molar missing, and when we do some restorative work either for the maxillary second molar or the opposing mandibular second molar, sometimes patients come back after a week or so and tell us that they are having food lodgement in between the maxillary 6 and 7. Now this is because in our restorative process we have left behind certain distalizing forces. Now what do I mean by that? Generally, whenever there are occlusal contacts on the mesial slopes of our maxillary second molar, and the mandibular molar comes and hits these contacts heavily, the molar gets pushed distally. Secondly, if we have a heavy contact on the distal marginal ridge, like you can see here, when the teeth occlude, this is the point where the maxillary molar is getting the load from the mandibular molar. When this happens in the distal half, this molar intrudes, and as a response in the mesial half, it extrudes. So the distalizing forces are on the mesial slopes of the molar and on the distal marginal ridge. And when we try to correct this, what we need to do is minimize these distalizing forces but try and maximize the mesializing forces. The mesializing forces are opposite to the distalizing forces. They are present on the distal slopes of the cusps and here on the mesial marginal ridge or the mesial fossa of the molar. So when we see the patient again, we have to use our articulating paper, mark these points and reduce the black dots, which are the distalizing forces or distalizing contacts, and try and increase the mesializing contacts, which are the red dots. Usually if our diagnosis is correct and our treatment is correct, the molar within 4 to 5 days, maximum 1 week, comes back into contact. The second molar comes back into contact with the first molar. If in a week's time this hasn't happened, the problem will be somewhere else and we need to address that separately. But our entire aim in this treatment is to try and increase mesializing contacts and try and reduce distalizing contacts. I hope that is clear. I will come back with the second occlusal reason for this kind of a problem in a few days. Share it with someone who might be having this problem or might be dealing with this situation. Thank you.